Okay, everyone. Thanks for being here today. My topic for today's talk is immune endocrinopathies, glands, and the game-changing checkmates. And I chose this for a few reasons. One is I just had an email like a week or two ago from one of the oncology providers, just kind of mentioning how many patients that they have and what guidelines do I use to get patients to you? Should I send everybody to you or should I send them at a certain time? So they were not sure. And the second reason for just my own information, because every patient is a little different and every checkpoint inhibitor class is a little different. So it's a little difficult for us to predict what's going to happen. And the patients always want to know, hey, is this going to be permanent? Is it just as long as I'm on the immunotherapy, or is it something I'll have to deal with for the rest of my life? Although they're very thankful to be on the treatment and to have, survival. So, that is something very important. These are my objectives, and mostly case-based. I'll talk about a couple of cases and also go over the pathophysiology. And anytime I give a talk, I always try to dedicate it to a group or somebody, and this time it is to all our patients who are cancer survivors or who succumb to cancer, and all those providers who were able to take care of these patients. So it is important to recognize, it's not easy to live with the disease, and for the family members and for the teams who made this possible. So it is, my favorite, Charlie Brown and Snoopy. And Charlie Brown says, someday we'll all die, Snoopy. And Snoopy, as wise as always the dog he is, says, true, but on all other days we will be living, we will not die. So, which is very important way to remember to celebrate life. And October 24th is the Great Pumpkin in PBS shows, those of y'all who like Charlie Brown peanuts. So anyway, we'll get to our case. And I wanted to thank Dr. Zinn for helping me with putting together the labs, because it's been a year almost since we saw this patient in the inpatient consult service. Very interesting case. 70-year-old male with type 2 diabetes, renal cell cancer, large mass, 8.3 centimeters, and with lung mets, and showed metastatic cancer, was planned to have cytoreductive nephrectomy. However, was sent from the pre-op area directly to the emergency room for headaches and severe nausea, anorexia, and confusion. And those symptoms are very important because I'll come to it in a few minutes, how that changes the presentation of symptoms is very important. And this patient had been already on 2 cycles of immunotherapy, nivolumab and ipilimumab, which is ER1. So MRI showed a slightly large pituitary. I was unable to get the cut actually that I wanted, so apologize for that. And the thyroid was, ultrasound was not very impressive, just sub-centimeter nodule, did show some heterogeneity, but otherwise normal. So these are the labs of the patient. These were initial labs. I hope everybody can see this on presentation when we saw him. So he was rather confused, and I don't have his electrolytes here, but they looked fine. Potassium was okay. However, these were his other labs because we were concerned about immunotherapy related effects. So his LH, FSH as here, and prolactin, and his PM cortisol, because we saw him in rounds in the afternoon and we just said, to save time, let's get a stat cortisol, and this was what it was. We did make sure that the patient had not been getting dexamethasone recently or has not been on opioids or any kind of steroid, epidurals or steroid inhalers. And the ACTH was less than 10 right here. And we did do a cosintropin test the next day. I think it was very flat, starting at 2 and ending at 6. I don't have the values here. And his thyroid function was also very interesting. TSH 0.06, and free T4 was 1.78, and the TSH going back into a different EMR was 3.3 about a month before starting the treatment that he had been on. Then his total T3 is 91, and his antibodies, we did check his antibodies and they were negative at that point. Subsequently, we diagnosed him as ACTH deficiency and hypopituitarism, started him on steroids. And his thyroid function over time, we did end up, because of mild hyperthyroidism, we weren't sure what exactly caused him the confusion and the other symptoms we had. So we did monitor him, and over time his T4 started coming down while he was in the hospital itself. So, and initially we thought perhaps it's sick euthyroid, perhaps. However, his TSH went on to become 22, so he eventually did go on replacement. And I just went back to see what exactly happened after a few months, and unfortunately he succumbed to complications of treatment, and he's no more. About a few months ago he passed away. So and his disease was quite progressive in spite of third-line treatment with other medications. This is a different patient. He is a veteran, and he had non-small cell cancer, and I've been seeing him for the last 5 to 6 years. He was treated with nivolumab, and at that time it was kind of early, so we didn't have too many patients, and his TSH on presentation was this, the one at the bottom of the screen, undetectable with very high free T4. I don't have T3 values here, but that was also elevated. But very quickly, within 3 to 4 weeks or so, or less than 6 weeks, he progressed to hypothyroidism very quickly, and we have replaced him. And it's also very interesting about these patients is that we go by weight-based, and many times you're actually under-treating them, and many of them end up needing higher doses than you would normally think they would. His antibodies were negative early on. I haven't recently repeated them. He had very, very mildly elevated thyroglobulin antibodies, and he had an ultrasound done about a few weeks later, and it showed an atrophic thyroid gland right here with no nodules. And this was after he became hypothyroid, because at that time we were not categorically checking everything like we do now. So that was after hypothyroidism. So that brings us to the actual talk. I mean, these are two different cases, and I still remember the very first case I saw of the ovoid-related hypophysitis, which was reported, and immediately we were able to, it was a Sunday afternoon. I don't know if Swapna is on the conference, but she called me around 3 o'clock. We had finished rounds. I'd gone home. She said, I think you need to come back to see this patient. So went back. Seldom do we have to go back and round on a weekend, but had to do it that day. This patient with extensive melanoma with cutaneous spread all over in her toes, everywhere. And then she had been given Ervoy, and she had severe hypophysitis, and we were asked to see her. At that time, she was already on high-dose Dex. There wasn't a whole lot we added to it, but it was quite an interesting case. That was our very first case, I think 2012 or 2013. I know that day was US Open. That's what I remember. So anyway, so cancer for us endocrinologists, the history as we see it is very impressive. The treatments, this book here was a bestseller several years ago. If you all have the time, you should read it. It's still a very interesting book for those of us physicians talking to our patients with chronic or very serious illnesses. So, and this shows this little mouse cat here guarding the mice which were there for the experiments, and this was in Berlin those days in the 1930s when they were doing experiments on for chemo on these rats, and the cat was guarding these mice. So it was kind of very interesting. So we moved on almost a century later, almost 80 years later, we have moved on further from the traditional chemotherapies to the personalized cancer therapy, that is immunotherapy. And they're all very interesting, different variations of it. In the 90s, it was the vaccines. In fact, I remember our cancer center here was one of the sites for the cancer vaccine. And then, of course, there's more recently, just in the last few years, it's the CAR-T, which is the chimeric antigen receptor T-cell transfer therapy, which is very unique. It's taking the patient's cancer cells and taking them out and putting them back in after going through this process here. It's engineering, cell engineering. And then, of course, the one that we are going to focus on today, which is the immune checkpoint therapy. And the immune checkpoint therapy, already the scientists have gotten the Nobel Prize, as you all know, in 2018. It's Dr. Allison from MD Anderson and Dr. Honjo here from Japan. And there's 3,000 active clinical trials evaluating T-cell modulators. And that's about 2/3 of all oncology trials put together. So it's kind of taken over the landscape and very impressive outcomes, but I'm not here to talk about the outcomes, so we'll go on to why we are interested in this area. So what is immune therapy? Let me just try and explain. I'm not an immunologist and I'm not very savvy with T cells and B cells, but I'll try my best to go over some of this information. So the T cells usually, what happens is when they're presented in the body with any antigen presenting cell or any tumor cells, usually they do develop these cell signals using B7 and CD28. However, they are not able to do much proliferation beyond that. They have receptors, but they can't go further or do anything much, mainly because of these checkpoints, checkposts called the Ctla and the Pd1, that they express. So what do these checkpoints do? So in normal patients, when the tumor cell is presented or any foreign body is presented, the T cells do get activated and excited, but then they recognize, they kind of look over and look at all the neoantigens presented by the tumor cells. But then they also start expressing these PD1 and Ctla agents, which is cytotoxic T lymphocyte A4 and programmed cell death agents. So these, when they start expressing these, the PD1 and Ctla4, the PD1 Ctla in turn turns off the T cell, activated T cell, and kind of weakens it and prevents it from responding to the tumor cell. So this is where the mechanism of inhibiting the Ctla4 and PD1 is very helpful. And also the PD1 or programmed cell death works through what is called as a ligand to program death, which is expressed by the tumor cell. So by inhibiting these areas, the T cell is able to cause destruction, release cytokines, and cause destruction of the tumor cells. So that is the whole kind of idea behind these immunotherapy or T cell agents or Ctla and PD1 inhibitors. But between those two agents, they are very unique. And one thing I forgot to mention is that these Ctla and Ctla and PD1 kind of dock on to B7 and CD28, which is expressed by the T cell and prevent the T cell from working. And when you use the inhibitor, the docking kind of is uncoupled and then the destruction starts happening. So that is an important step also. So more recently, individual treatments are not used. Instead, the Ctla PD1 is combined many times with other agents, which could be vaccines, cytokines, and also the traditional therapies such as the anti-angiogenic and chemotherapy, radiation, etc. So we have a lot of trials. In fact, one of the areas of interest in thyroid cancer by ETOG, which is the International Thyroid Oncology Group, is combining PD-1 agent Keytruda, pembrolizumab, with lenvatinib, which is a protein tyrosine kinase inhibitor. So those are a lot of, there's been a very impressive results with those combinations in advanced cancers, thyroid cancer. So what are the different agents, and what was the kind of the trajectory of this immune therapy? So in 2011, the first one agent was first approved by FDA, and that is Yervoy or ipilimumab. It's always a tongue twister, so I have to kind of say it very slowly. And so ipilimumab acts on the Ctla4 agent, and then the other agents, which then later on within a year or two were approved, were the nivolumab, pembrolizumab, and semiplimab. I'm not very familiar with semiplimab, but we are all very familiar with nivolumab and PEM. And that is PD-1 or programmed cell death inhibitors. And the PD-L1, which is programmed cell death inhibitor, ligand inhibitors, and that is atezolizumab, durvalumab, and avelumab. And we are familiar with these agents also. We do see a fair number of patients. And those are the different agents, and these are approved indications for majority of the solid cancers. Traditionally, it was melanoma was the very first one that we recall starting seeing patients, and then it was renal cell cancer, colorectal, and as far as more recently, we have seen pancreatic cancer trials also, and of course, like I mentioned, thyroid. So some of the other tumors are Hodgkin's, non-Hodgkin's, urothelial, colorectal cancer, such as Lynch syndrome. We have a few patients with that also. And then also Merkel cell cancer, which is a skin cancer, cervical cancer, urothelial malignancies, and renal cell, of course, traditionally, and also triple negative breast cancer, which is again more recent. So those are the different myriad kinds of solid tumors that these agents have been used in. And there are some key differences between the Ctla4 and PD-1, and we'll see that more and more as we go through this presentation. So the Ctla4 is more hardwired, and it targets the CD28 helper T cells pathway, and it works mainly by priming of the naive T cells, and then it works by draining lymph nodes and expands clonal diversity, and it affects primarily the CD4 T cells, and it can move the T cell into cold tumors, and often the response is a bit slower, and adverse events are more relatively more frequent, as you will see, and also recurrence after response is quite rare, so it's quite effective. The PD-1 agents, they induce resistance, and they target the TCR, which is the T cell receptor pathway, and they work mainly on exhausted T cells, which is, when they're inactivated, they become exhausted, and this kind of rejuvenates those T cells. And it works mainly on the peripheral tissue and tissue microenvironment, and it does not expand clonal diversity, unlike the CTLA. And it also affects the CD8 as opposed to CTLA, which is 28. And the clinical response is quite rapid, and also adverse effects are a little less frequent. And however, disease recurrence does happen. So while the not minimal, less compared to CTLA, but then recurrence is there. So those are the differences. So if you're talking about adverse effects, one wonders if they're not traditional adverse effects like the traditional chemotherapy that our patients used to go through until early millennium. So what are the adverse effects we are looking at? Well, 10 to 60% adverse effects or immune side effects. Of course, there are rare fatalities such as encephalitis and myocarditis, but more common are these other areas such as the endocrine adverse effects and some other adverse effects, which I'll list in a minute. But it can pretty much affect anywhere head to toe, if you will. And the patients usually say they get pages and pages of side effects to go through, but they know that this is better than the alternative, and they're happy to, live through it. So some of the non-endocrine side effects, fatigue, which is something we all struggle with. I know even Dr. Mokshagana mentioned the other day about a patient he had who's already on the replacements of all hormones, and that is common thing that we struggle with. And I'll talk a little bit about that. Skin rash, itchiness, diarrhea, and transaminases. They can have autoimmune hepatitis. Colitis is actually more common than hepatitis. Pneumonia, anorexia, arthritis, mucositis, fever, nausea, myalgia, and of course xerostomia. As far as the endocrine side effects, which is immune checkpoint endocrinopathy, so we call it ICE for short term. This is, the blues are all PDL1, orange is PD1, purple is Ctla4, and green is the combination therapies. So hypophysitis, the more common with the combination, most common, and of course the next more common is Ctla4. And hypothyroidism, again, as you can see, the combinations are a bit stronger in terms of side effects. And the Ctla4 hypothyroidism is kind of equal to PD1, and hyperthyroidism pretty mild actually in most of them. And diabetes, which we'll spend a couple of minutes on, is not so common, but when it happens, it's pretty fulminant many times. And duration or time of onset, usually it can, in terms of months, it can start anywhere as early as 3 weeks all the way to much later in the course of time. And so that is pretty varied, and that's why it's important to keep an eye on these patients and have a protocol available. So in terms of side effects, I have listed all of them here, and these are the different studies that they were looked at in. And as you can see, all of them individually in all the studies, there was a significant amount of endocrinopathies, including the nivolumab studies. There was hyper and hypothyroidism, and the Irvoy studies, endocrinopathies as a whole, 8%. And the combination, as I said earlier, anywhere between, when a patient or anybody asks what are the side effect percent, it's anywhere between 9% to 30%, depending on the medication used, depending on the patient's history, and depending on if there are combinations. And that is something important. We'll start off with going over a few words about the hypophysitis. And it's quite an impressive looking pituitary MRI right here with it's a sagittal view and a coronal view, and it shows absence of the posterior bright spot here and heterogeneous appearance right here. And this is a patient who underwent pembrolizumab along with cisplatin for head and neck cancer, laryngeal squamous cell cancer, and he did develop hypophysitis, as you can see here, and also hypothyroidism, and also this is the pancreas right here, and it's kind of edematous, and also developed hepatopancreatitis, pretty severe. So those are some of the effects. This is a PEM patient. So what is the pathophysiology of immune-related hypophysitis? Well, interestingly, in immune-related hypophysitis, the pituitary cells have ectopic Ctla expression in the hypophyseal area, and also that kind of helps the Ctla, the medications dock on the Ctla expression and cause those the hypophysitis and the effects of it, which could be anywhere from just isolated ACTH deficiency to hypothyroidism, and rarely diabetes insipidus, such as the patient that I just showed, who had the absence of the posterior bright spot, and also sometimes hypogonadism, although that's a little bit difficult and challenging challenging to evaluate when they are quite ill. So that is kind of the mechanism. And also, I didn't add the slide here which showed the stain with the anti-pituitary antibodies, especially the TSH antibodies, which were also present in some of these patients when they checked them. So that also is one of the other mechanisms of hypophysitis. So what are the different presentations of hypophysitis depending on the medication used? Well, in terms of time of presenting symptom, the Ctla4, about the 3rd to 7th treatment cycle, they start expressing it. They do present with a pretty intense headache many times, and that is the patient that me and Dr. Zinn had seen. And the deficiencies could be over more than one anterior pituitary hormone. DI is not very common. DI is only seen in case reports. And in the MRI, like our patient did show the pituitary fullness or hyperplasia, and there's homogeneous or heterogeneous contrast enhancement like the one I showed, and many times there is infundibular stalk thickening seen. In terms of PD1, PD-L1 patients, it is again could be seen the 7th to 13th treatment cycle. They present mostly with just fatigue. They're not as sick as the other group. And many times they just have isolated ACTH deficiency. And usually, again, it could be normal appearing MRI or there could be some enlargement. Either can be seen. Now, what about combination patients? And when there is a combination patients, the incidence of this ICI or hypophysitis is about 8.8%. That's pretty high, actually, especially the one which is the patient that we saw with Ctla4 and PD1. They presented with confusion, headache, blurred vision, hypotension, fatigue, everything, and they do end up having more than 2 axes also, just like Ctla4 patients. And let's see, so that is about, and the duration of onset for the PD-L1 can be as long as after a year, 52 to 56 weeks. And in terms of Ctla, it can be as early as 6 weeks. So that is something to keep in mind, that the duration can vary and they can have different presentations. So they do grade hypophysitis in these patients, and that's important to know, and I'll tell you why in a minute. So grade 1 is their asymptomatic, very mild symptoms, clinical or diagnostic observations only, and many times no intervention may be required because it could just be that they just have a pituitary slightly enlarged, but all the axis numbers look fine. Grade 2 is moderate symptoms. They may, depending on limiting age-appropriate instrumental activities may be required. Grade 3 is pretty severe or medically significant, but it's not life-threatening. And it may prolong hospitalization, and it may limit also self-care, such as the patient we saw. Of course, grade 4 is life-threatening and immediate urgent intervention. Grade 5, we really don't want to see that, but that is very undesirable kind of a level. So in terms of, I think our patient, I would call him probably a grade 3 to 4, the way he presented. He was quite ill. So let's see. So usual presentation, at presentation when they have fatigue, headaches, visual changes, hyponatremia, some of the presenting symptoms, and labs including ACTH, cortisol, and this is always an issue. Patients have had large doses of DEX in the past, so it's hard to say what exactly is going on. Fortunately for our patient, there was no DEX. We were able to go back and check into the EMR or also talk to the oncologist in this case. And also, many times we get called by the time we round, it's evening, but I would say any time of the day when they're in the hospital, just get a cortisol level as soon as possible. And also thyroid function, including TSH free T4. Now remember, I'm presenting this data from the oncologist side. Interestingly, we have no guidelines by Endocrine Society or ACE or anybody about immunotherapy checkpoint. We are just kind of presenting recommendations, proposed algorithms. One came from NIH in a journal, oncology journal, and one recently is published in one of the endocrine journals or in print right now from Mayo Clinic, but we really don't have guidelines. So usually these algorithms usually say at some point, consult endocrinology. So, and if you see that, don't be surprised, because I'm doing that in an endocrine conference. So, and of course, growth hormone, prolactin, IGF-1 could be measured, but very important to know IGF-1, even though if they have growth hormone deficiency, we are not going to replace in a patient who has active cancer at this point. That's something to remember. And gonadotropins can be measured, although when they're very sick in the hospital, you may not have accurate numbers. So all labs, if they're within normal, so we usually go ahead and kind of monitor them, or in this case, our patient, he also had thyroid abnormalities, so we had to replace it. So it says here endocrine consult, and then grade the hypophysitis, and which we went over right now, and adrenal insufficiency treatment. So grade 1, we usually replace the hormones and continue immunotherapy, no interruption, because that is another thing important to discuss is, does immunotherapy have to be interfered with? Grade 2, we start immunotherapy, hormones, and continue immunotherapy and monitor symptoms, and also consider steroids if their symptoms don't improve. If their cortisol axis is fine, you still may need to give them steroids. And then grade 3 and 4, pretty significant. These patients, we have to begin steroids 1 mg per kg per day, prednisone or equivalent, add hormone replacement, and we hold immunotherapy in these patients. So anybody who's that sick to be 3 or 4, immunotherapy has to be held, and restart only if the benefit outweighs the risk, and monitor symptoms in these patients. So something very important to remember in these patients is the dose of the treatment. So most of them, which I'll come to in a minute, if they are grade 1 or 2 and if they have hormone deficiencies, there's no indication to use high-dose steroids. And that is something that's been stressed a lot, and I'll show it in the upcoming study. So this was a study of 117 melanoma patients treated with ipilimumab, and they developed immune hypophysitis, almost 13% actually. And this was a study from University of Iowa, published in Pituitary 2019. And these patients were, the highest risk patients were men, and also age, older they were, higher the risk. And also if they had no prior cancer therapy, also they were at a higher risk. And when they looked at immune hypophysitis and survival, there was no connection there. And something else very important that they noted was that using high-dose steroids should be reserved in cases with severe headache or visual disturbances. And of course, we should hold the therapy until they recover from that. So, and it's one thing to know is immune hypophysitis is distinct from the primary hypophysitis that we have previously seen in the pituitary clinic, such as in primary hypophysitis, usually women, it's predominant in women, whereas here it's men, and younger women usually, and this is older men, and a shorter time of onset, and the ACTH deficiency is pretty severe, and there's no posterior pituitary involvement in immune hypophysitis as opposed to the usual primary hypophysitis that you see, and no optic chiasm involvement. And also, sorry, the print is fine here. Ctla4 patients usually end up having pan-hypopit, not including diabetes insipidus, but other anterior hormones, whereas PD1, it's usually just ACTH deficiency, less hormonal deficiency. So, and that is that. So, and like I mentioned earlier, high dose supraphysiologic doses of steroids are reserved for patients with optic chiasm compromise, visual field defects, cranial nerve palsies, or very intractable headaches. And it's not appropriate for mild acute cortisol deficiency. Physiologic glucocorticoid replacement will suffice. And the data that supports this is from the study. Somehow I missed the reference here. It's a study comparing low dose versus high dose steroids. And here, when they talk about low dose, actually, it was just 5 milligram prednisone, which is like your physiologic dose. And high dose was equivalent to over 20 milligrams. So that's not even much that much high when we think of the dose we use in the hospital. And as you can see, in terms of percent survival and percent without additional treatment or death, there's a big difference between the low dose and the high dose, and that is the reason that it's stressed to use lower doses. And then adrenal failure, not much different. That is the next area that we look at. And usually presentation, it's not as common as the hypophysitis. Presentation is weight loss, fatigue, hyperpigmentation, hypotension, hyponatremia, and hyperkalemia, which we are all familiar with. And evaluation includes, as we all know, ACTH and cortisol. Well, something important to remember is when we see more patients for thyroid dysfunction than we see for hypophysitis. So it's very important when you start replacement for these hypothyroid patients that we always get a cortisol level, because they could have a silent, like a primary adrenal insufficiency, and it can be quite subtle. So it's important to measure their cortisol levels before we start them on thyroid replacement. And that's something they stress upon again and again. So again here, mild, moderate, severe. If there's crisis, hold the cycle of immunotherapy, rule out sepsis. There were several case reports of adrenal crisis and sepsis together, and then hydrocortisone 100 every 8 hours and fluid resuscitation depending on the hemodynamic status. So that's very important. And moderate cases, 10 to 30 milligrams of hydrocortisone and fludrocortisone along with that. And of course, crisis, they can present with confusion, pain, and we have had one patient, or more than one, maybe 3 or 4 with adrenal crisis with pembrolizumab, I think, along with type 1 diabetes. Thyroid dysfunction is the most common one that we see, almost up to 30% in combination therapies. And baseline evaluation is recommended. So oncology team does do a baseline thyroid function tests in most of these patients, or all of the patients, based on their protocol. And typical presentation is a very mild, painless thyroiditis initially within 3 to 8 weeks, or it can last up to 2 months sometimes. And immediately following that is usually hypothyroidism in almost 50% of the patients. Very rare to have Graves' disease with TRAB positive or Graves' eye disease, although there have been case reports. And usually the hyperthyroidism phase is extremely transient. We just kind of hold their hands, give them some beta blocker or NSAIDs if they have a lot of neck pain, but most of them don't even notice it. They immediately become hypothyroid. So majority of the patients do not need any treatment for hyperthyroidism, because eventually within a few weeks they do go into hypothyroid. The hypothyroidism usually happens within 4 to 6 months of the initial phase, and we should not forget that some of them can be central hypothyroid, so getting a free T4 is also very important. Just doing a TSH may not give us the full picture. And also, like I mentioned earlier, screening them for adrenal dysfunction before replacing. And of course, just like in any other case, some patients are quite sick, and when you see abnormal looking thyroid function tests, such as a low TSH, it is confusing. But most of your sick thyroid patients, the T4 is actually not that low unless they're extremely sick. So when there's hyperthyroidism, normally, usually these patients are sent to us. We are not seeing them in the clinic initially. And if their symptoms are quite, intense, such as weakness, tremors, palpitations, high heat intolerance, and usually most of them end up not needing much, like I mentioned earlier. Here again, they do grading. I think we are not familiar with doing grading in hyperthyroidism, because we see a patient, I guess we do grade them in a way. We look for STORM in every patient who walks in who's hyperthyroid. So that is our grade. But for oncology, they use a different kind of grade based on the labs. And should they or should they not continue immunotherapy? That is the most important question they have. Or should they not consult endocrine? So when they are grade 2, which is symptomatic and limiting their ADL, then they have their own performance evaluation. Then they say, consult endocrinology. And they talk about radioiodine uptake here, and which actually it's not recommended. This again was a proposed algorithm. It's not something we do on a regular basis. Usually by the time you schedule the radioiodine uptake, patient is already going into hypothyroid phase or is euthyroid. So majority of the time we don't. But if the thyroid abnormal thyroid function, which is hyperthyroidism, lasts longer than a few weeks or if patient is symptomatic, certainly at this point, checking their antibodies and doing uptake scan and thinking about Graves' disease is important. And of course, beta blockers and methimazole if they have Graves' disease, or if it's subacute thyroiditis, which is the usual picture, beta blockers and continue immunotherapy and wait for them to become hypothyroid. I'll skip the part about grade 4, which you all here are experts. We have seen enough storms or storm risk patients here, so won't go into it. The next is hypothyroidism, which again is the most common condition we get consulted for. Again, here there's a grading system, and the grade 4 is I think grade 3 is a patient we just have in the hospital that Dr. Kuram and I just saw a couple of days ago. He's actually doing better, thank God, which was a combination therapy for non-small cell CA, I think, with metastatic non-small cell CA. So again, the oncologist, the question is immunotherapy or no, continuing, and then levothyroxine dosing, which again is a challenge many times. Interestingly, when these patients get hypothyroid, they rapidly, the TSH goes up as high as 80 because oncology is checking them every week. 1 week it's 10. By the time you see them again, within 2 weeks when they see for the next cycle, or 1 week it's like 7, and you tell them they look fine, let's just wait. For the 3rd week when they come back for their cycle, the oncology provider calls you and say, hey, the TSH is like 100, what do I do? So it happens so quickly, but still it's important at this point to make sure they don't have adrenal insufficiency and then get started. The recommendation based on the articles I read, they say anywhere between 0.5 to 1.5. And also some say 0.8 is a dose to start with and slowly increase. We have noticed in our group here, which again, we haven't done any systematic review of the patients, that majority of them end up needing higher doses based on their weight. And that could be because of other GI issues that they may have. With the colitis, I don't know if they have absorption issues or other problems that they may have, which prevents them from getting to therapeutic doses. And we also have patients who are pretty severe fatigue and have asked me about adding T3, and we do discuss that once they are in remission and completed their therapy. But I try not to do combination while they're going through therapy. That's also, again, very important to think about it. And there was something more about hypothyroidism. Most of the time, antibodies may or may not be positive. So antibody positive state does not predict hypothyroidism in most of the patients, interestingly. Although Hashimoto's antibody positivity does predict, but here it does not. But if they have positive antibodies, it does help to trend the antibodies to see how they would respond. So this is an interesting study done by the Mayo Group, Mabel Ryder. I think some of us here know her well. She came here a few years ago and gave a very nice talk. PD-L1 inhibitors have a 25% risk of thyroiditis, and it's the most common effect in these patients. And usually, like I mentioned earlier, there's a toxic phase, and severity depends upon, the severity of presentation is what dictates how you manage these patients. And I didn't put the picture here, but there is a very nice FDG uptake PET scan where diffuse uptake of the thyroid actually predicts that they're going to develop hypothyroidism later. That's one factor that can predict. And there's one more factor, which I'll get to next. And also, the antibody, like I said, doesn't predict development, but if it's present, it predicts the severity and the cause. And let's see. Okay, we go to the next one, which is kind of brief. It's, I'll see what it is, right? It's the pancreas very intense uptake on PET scan of the pancreas, and this is a very nice article from 2019 about type 1, or we don't call it type 1, it's insulin dependent or autoimmune diabetes with checkpoint inhibitors. And these are a very unique group of patients, and again, when they present, it presents very rapidly, and this is a PET scan that shows the uptake in the new insulin-dependent diabetes patient with increased uptake in FDG. Both PD1 and PDL1, that is the ligand inhibitors, can cause insulin deficiency, and they can develop diabetes. The percent, depending on the studies, is 0.9 to 1.8%, depending on which studies you're reading. And this was a very nice study. I think it was a combination from Yale and UCSF together. They probably had the highest number of patients. They looked at 3,000 patients over 6 years from two combined university institutions, and they had about 28 patients, and they looked at the trends. And interesting, the dark areas are patients who had no previous checkpoint treatment. The gray circles are those who have had previous treatment, and also these are the week start and all the way up to several weeks later. And let's see, gray symbols. And the treatment cycles, the numbers here are like 3 cycles for this patient, 3 here. Some patients developed after 78 cycles, so they were pretty varied. But they had about 27 patients, and like I said, Yale and UCSF, and none of them they recruited patients who had no history of diabetes or had type 2 previously on oral agents, and now once you start treatment, they're requiring insulin. So that was their criteria. And they looked at patients who required insulin for more than a month, and with evidence of insulin deficiency in these patients. So, or those who presented with DKA and with lower absent C-peptide levels. And they had about, I think, very few patients that they had checked antibodies on. And there were 3 patients that they had fortunately checked before and after the incidence of the diabetes, and at least some patients had positive GAD antibodies and islet cell antibodies prior to, but not all of them. Most of them had negative antibodies. And you can see here the spectrum of frequency of the antibodies once they were diagnosed. Several of them did have GAD as opposed to the control, and some had insulin islet cell antibody, and actually islet cell was very few. Amyloid antibodies were present, so some of them had that. So that is interesting. So what is the mechanism? It's a 2-hit hypothesis. Number one had to have a genetic predisposition. And then number 2, based on the genetic predisposition, then the beta cell undergoes stress during the treatment. And then there's immune response priming with expression of PD1 on the beta cells. On the pancreas, if you will, and then recruitment of the antigen presenting cell CD8 to the pancreas, and then exposure to the PD agents, and that causes the pancreatitis. It can be pretty fulminant type 1 with DKA. Some of you have seen those patients in the hospital. They are quite sick as they come. So it's important to recognize them early, and the recommendation is to actually start doing A1Cs or assess their diabetes risk even before they start the treatment. And like I said, not all of them had pancreatitis. Only 42% had pancreatitis based on lipase, amylase, and imaging in the peridiagnosis period, and 40% had at least 1 antibody, 21% had 2 or more, and there was a predominance of HLA-DR4, like I said, a genetic predisposition, which was 76% of those patients who developed the diabetes, and also some of the others, 70% of them had other immune side effects such as thyroid or hypophysitis, and 44% had endocrine side effects. And overall, about 73% of the patients had partial or complete response to checkpoint inhibitors based on their criteria that they used. So, and which brings us to one of the outcome studies that I was just going to show before closing. There was one case report of autoimmune hypoparathyroidism, but that was just one or two cases, not too many, as you can see here. That was like so many, I think about 220 days they were on it, and then they developed it after 220 days. And they needed treatment. And there was one of a polyendocrine syndrome type 2, which is Addison's type 1, and hypophysitis, a patient who was on atezolizumab. And they had 21-hydroxylase and pituitary antibodies positive in these patients. So, and they did have the HLA typing positive. So what are the predictive factors? Like I said earlier, there's not a whole lot of predictive factors. The only one that they found in this case series of over 200 patients was if they had previous endocrine disease, some of them were at a higher risk for endocrine toxicity when they started any of the PD1. That was just one, but just nothing else, age or gender, none of them did recognize any of these patients. But there is some good news, or if you want to call it silver lining, with having endocrine side effects with treatment of immunotherapy, and that is impact on overall survival in these patients. And this was a study again from Mabel Ryder's group in Mayo, and they looked at almost 100 patients who developed thyroid effects, which is about 25%. PD1 patients, and one patient had type 1 diabetes, but they categorized them under the control group. And most of them had hypothyroidism. Some were mild and some were overt, and some did recover, but not all of them. And I won't go into the details of their individual things like uptake on thyroid, FDG, PET uptake, free T4, TSH, and other antibody titers, and etc. But this is what is very interesting. These are survival plots, overall survival probability. If you had a thyroid immune-related side effect versus if you did not, and it was pretty impressive to look at, if you had thyroid side effect or immune thyroiditis, you had a higher chance of survival compared to those who didn't. And that was pretty impressive. So to go through what the patients go through and to tell them it is like the COVID vaccine, if you're sicker, that means you develop more antibodies and you did better. And that goes with, this was another study, I think it was done just recently published, looking at overall survival. These are Kaplan-Meier survival curves with any endocrine toxicity, not just thyroid. And there was some difference, at least for part of the time in these patients in terms of overall survival. And also looking at, I think, progression-free survival also was quite impressive in many of them for any endocrine side effects. So knowing that is, kind of helps design other future, treatments for non-thyroid cancer, these are all non-thyroidal cancers, but this is just another interesting patient who was treated for melanoma, but incidentally, the FDG PET did show a thyroid intense uptake. It ended up being PTC. However, patient at that time, melanoma was a priority, so they started the treatment. But as they progressed through the treatment with immunotherapy, the PTC disappeared. And that was one of the papillary thyroid cancer. That was one of the reasons that it was felt like this would be a great area for our thyroid cancer, advanced thyroid cancers also. And we'll see a lot more on that. We have been seeing a bit on that in the last 1 or 2 years, and we'll be seeing more. So as of now, the guidelines we have is from the NCCN and from Immunotherapy Toxicity Working Group, and not necessarily from endocrine area other than the few articles that I presented, but it's a great area to work more and look at trends. We do have a significant number of patients both between the VA and here. And something to remember, to start checking thyroid function with every cycle, which our providers are very good about it. And the complications can develop within 4 cycles of commencing treatment. And they are not a reason to discontinue treatment, but it's important to remember if they're very sick, hospitalized, and grade 4 of any of the diseases, then you need to hold the treatment. And these numbers are here. When it's isolated single agent, the percent occurrence is less compared to combination therapy. It's as high as it could be 30% sometimes. So the other issues, fatigue is a big issue, and we look at, I've had a patient who had severe fatigue. I had to cut back his opioids slowly, and that actually helped a little bit. And of course, checking vitamin D and looking at other areas, replacing testosterone, all that helped. And the dose inconsistencies, and do they need T4 and T3 if they continue to have fatigue? Those are areas that no one has really studied or looked at, but it's a very interesting area to look at. And also looking into the future of how to go from the bench to preclinical area to the bedside and to give the patients the best of the benefits. And I know our pediatric colleagues are here, but when I looked up, I couldn't find a whole lot of data. I did invite the pediatric oncology team, but I think they had a PCORI meeting going on, so they were not able to join us. But I do not know their experience with the checkpoint inhibitors. So I will stop here and take any questions. Does anyone know what this, these are the different pins from the different cancers, but I was just wondering, does anyone know what this one is? I mean, you may be able to tell me the others, but this one here. Any guesses? Dr. Mokshiganam, do you know this one, the green? It's hepatic hepatocellular CA. This one here is head and neck. Yeah. Thyroid is right here, and this here, the zebra, is actually carcinoid. So, and this here is our code today. So thank you all for your attention, and I'll take any questions. You can turn the lights on. Oh, sorry, yeah. Oh, did I close it by mistake?
No, you said just to stop sharing.
Oh. No, this looks different. Dr. Mokshiganam, I don't see the screen here. What is it?
I can see it.
Yeah, I know, I can, but I don't see that here.
Oh, that's because you're on the...
Can you come on? Yeah, I see it there, but I don't see it here. Is it here? Oh, there. Now I see it. What was that? Oh, blue jeans. Okay.
Yeah.
Never mind. Sorry. Oh, no questions yet.
So the thing that you had on the last thing, was that the prevalence or incidence on the number of, for each of those you had this percentage of hypothyroidism?
So that was actually prevalence.
Okay.
Yeah. Because all the studies were like kind of course, there is the studies that I showed, the Checkmate and some of the other studies. They did give their...
because it didn't look very high. That's why I was a bit surprised.
Actually, some of them were 9, depending on the studies you looked at, some of them were 9 to 30%. There was as high as 30, but the lowest earlier on in 2018 when Allison, the Nobel laureate from MD Anderson, and Priyanka Iyengar, when they presented, it was 9%. But as we went on and we saw more and more and more, depending on which agent and what they had. And the study that they did with the type 1, type 1, they looked at not just type 1s, they looked at type 2s who kind of became insulin requiring also. So they kind of included them also in that. And the same with the thyroid, some of them also picked, when the studies, pre-existing hypothyroid patients whose doses now quickly escalated up and there too. So I think many of them did include, and some of them didn't include that. So it varies based on which data you're looking at. So thank you, Doris. Good to see you. Don't see any other questions here.
Where is your? Can you see your? The chat box?
Yeah, Doris said, nice. That's it. So, yeah. I don't see Dr. Winters today. He's there. I'm not sure.
So there's nothing you can do to prevent.
Yeah. So the only thing you could do is to, I guess, monitor them based on their NCCN guidelines, and based on the symptoms. I mean, the patient that we saw in the hospital with a hypophysitis, he was quite sick. And the one that they had adrenal, which we see him in the Keytruda patient, the PEM patient in VA, he had both Addison and he had type 1, both. And we have him on basal bolus and Dexcom. And his Addison's, he required slightly higher doses. One thing which was valuable I learned from this is, just because they're fatigued, I can't keep ramping up their doses, because they say it doesn't help with their outcomes. And unless they're grade 3 or above, we shouldn't be giving them high dose steroids, which to me was surprising. Because with that patient, he was so sick, he was confused, and his cortisol was negative. I said, okay, I'm going to give him high dose. But of course, he had the symptoms, headache, confusion. So, but they say normally we don't need high dose steroids. Just physiologic replacement is adequate in most of them. So, which again, to me was.
Well, the thyroid also, you said they need higher dose. So have they tried T3?
Yeah, that is the other issue I had. And again, these are individual patients. I had one patient who had hypothyroid, and she's completed a treatment. I think she had nivolumab, and she's now extreme fatigue, and she's on T4. And just last week we discussed and we decided to go with T3 because she just has horrible fatigue, and she's completed her treatment, so there's nothing else going on. And her adrenal axis is fine, so there's no problems there. So